And now I'd like to introduce our speaker for the day, Carole Yann. Carole is the Acting Director of Fiscal and Business Operations for the Oregon Public Health Division and has worked in public health since 2008. Prior to this role, she was the section manager for the Oregon Medical Marijuana Program, where she oversaw the creation and implementation of stricter regulation of the medical grower population and changes to the program with the legalization of recreational marijuana. Before coming to public health, Carole was a founder of a magnet school and a regional manager for a savings and loan. She holds a bachelor's degree in business administration from Portland State University. Carole will be sharing Oregon's experience and journey to promote the value of prevention, and we look forward to a very engaging and interactive session throughout the hour. So take it away, Carole.
Well, thank you. I'll wait for the PowerPoint to come up. So yes, so I'm going to start us on our journey, and I'll just walk through what we have done. I'll give you some timelines and then a little bit more detail behind it, but it's a journey that I would say that we're really just beginning to implement. So it is exciting and a journey, I'll just say, because it's lots of steps. Go ahead to the next slide. So public health, and in Oregon's public health system, we have a very decentralized public health. Our local public health agencies and tribals have their own authority over the public health functions within their jurisdictions. We have distinct yet mutual supportive functions. In our public health system, we are a division within the Oregon Health Authority, and our division receives about 3% of the budget that Oregon Health Authority receives. That's what we received in the 17-19 biennium. And a majority, as probably with many of you, a majority of our funding comes through federal funding for very categorical grants and programs. And it's a challenge when you are trying to modernize the work that you're doing, because we don't always have the funding in the structure that we have now to be able to address emerging threats or health priorities within Oregon. And there's only a small portion of our federal funds that can be used to help support that infrastructure that's not tied to specific health outcomes. Go ahead to the next. So for Oregon, this is our triple aim, and it is Oregon Health Authority. So it's the goals that we have set as what we want to accomplish, which is better health, better care, and lower costs. Our public health system implements programs and policies that make it easier for Oregonians to live healthier lives. We provide access to preventative health services, and we provide a system that works to prevent disease and disability, which helps to reduce the long-term healthcare costs like diabetes, heart disease, and HIV. One of our really main roles and functions is the data, and we collect and report on a lot of health data. So, go ahead. I'm going to talk a little bit about the timeline of our journey and kind of where it started, and this slide doesn't have the current biennium on it, but it'll give you a history, and then I'll give you a brief overview, and then in the next upcoming slides I'll get into a little bit more detail on it. So we started the journey in 2013, and the initial journey was a task force. So for Oregon, we had one of our representatives, Representative Greenlick, was very thoughtful and visionary in knowing that we need to do public health different. And they worked together, they created a task force to kind of walk through that. What does that mean? What does it mean to be modern? What needs to be included in that? And they put together a plan, a visual, which I'll show you in a bit, as well as a report that went to the legislature. Then In the 2015 legislative session, we had the House Bill 3100 that was passed, and that was the first amount of money that was actually given for this work. We received $500,000, and the purpose of that was to really assess and analyze the gap. So, you know, you have funding, you do public health work within the state, where are your gaps? So what we did is, the end of that was to then put forth an assessment report, and again, I will get into that. And then the last part of that, as far as on this, is that in 2017, we received our first installment of $5 million to begin focusing on that investment and beginning to change the work. And then in the 2019 session, what we did is we put forth a policy option package to continue the investment in public health. And at that time, we received an additional $10 million. And I'll get more into that nitty gritty into that in other slides. Go ahead to the next. So step one was the assessment. And so again, we received that initial $500,000, and we did complete a gap analysis. And we did that at both the state side as to, you know, what work we had, and at the local side with all the public health authorities. It was the role that I'm in to lead this work and determine how the process was going to work, what data we needed to collect, how to get that information, and then how to share it. We did hire a consultant to assist us with this work, and they've worked both with the state and at the local level. And the modernization assessment report was then developed, and that went to the legislature. And in that report, you have, you know, a description of what it was, the tools that were used, the summary of what the states were currently providing, and then also what the financial estimate as to what would be needed. And it had both the individual state and local public health findings included in that. I have links in this document to those documents, and at the very end of the presentation, I have a link to the website that has a lot of information about modernization for you to look at. The one thing that the assessment report, it talked about because this was done in 2016, that in the 2016 dollars, we needed an additional $105 million to actually have a fully modern system. So shows you the gap. Next slide. So this is the document that was created and developed by the initial task force. So what we did is we looked at, you know, what does make a system modern, and what do you need? And these elements were found in all local and in state. So we had foundational capabilities, is that you need leadership and organization capabilities, health equity and cultural responsiveness, community partnership development, assessment and epidemiology, policy and planning, communications, and emergency preparedness and response. So those were our foundational capabilities. And then we determined that we have foundational programs, and this work is critical for Oregonians and touches basically all Oregonians. And so that's your communicable disease control, prevention and health promotion, environmental health, and then access to preventive services. And layered on top of that, we have many other programs, but that also continue to contribute. These ones were determined to be the core and the basis of the work that we would be doing to modernize public health. Excuse me. What the goal is for this is that a modern public health system would be protecting people from the communicable disease. It would be preparing and being able to handle emergency responses. You would have would be limiting your environmental risks. You would be continuing to promote prevention and health, and you would ensure equitable access. Next slide. One of the main changes I think that we have made in Oregon is how we're looking at how we want to really look at maybe the baseline problem. We have modified our state health improvement plan to have new the different priorities this next 4 years, and this is kind of the umbrella over it, is that we want to look at the social determinants of health and the impacts that they have, where you have the reality is 10% of your time is in a doctor's office, but there are other elements of that affect your well-being, and social and environmental factors are a critical part of that. We talk about we spend as much as other countries on healthcare, and why aren't we healthier? Part of it is that are we focusing on ways to actually change it? And for Oregon, utilizing the state health improvement plan, working with partners, we are really shifting our focus on how we are looking at that. And we're looking at institutional bias, we're looking at adversity, trauma, and toxic stress, environmental drivers of health, including issues related to housing, living wage, food security, access to equitable preventive care, and behavioral health, including mental health. So that has kind of been the umbrella over all the work that we're doing when we even think about these core foundational programs. Next. So next slide. So you think about, how do we get this information out? How did we start doing it? Well, within public health, we have numerous teams. So once we started on the journey of the public health modernization, we created a team, and that team included our public health director. The way that we are set up is we have administrators over different programs in our division, some that focus on prevention, some that are more practice oriented, and some are more prevention oriented. And then my role is in this group. Our policy director, we include government relations, and we include our communications, so that when we are working on any implementation, that we're trying to make sure we are addressing it from all different angles. It's very important. We have the support of our Oregon Health Authority director. He supports the vision and the work. We also have our public health leadership team, and that group is who guides the work and who has kind of continued that. And many of the same people are on the modernization team. That is more of an expanded team, but our leadership team includes the director, the center administrators, CFO, and our policy director. So we are very integral into how this work goes forward. We also work closely with our government relations and communications. And as we were building this for every biennium, when we wanted to go, put a bill forward for this work, as we developed that, our government relations team was very critical. They worked tirelessly with our legislators in setting up meetings so that both the Oregon Health Authority director and our public health director would meet with our government relations and all of the key legislators, so that when we went to the legislature with our bills, they had an idea of what we were doing, what the reason was behind it, and we were just continuing to educate them on public health and the importance of public health. I think we've all, kind of had this feeling in the past that nobody cares about public health until there's a crisis, because if things are going along well, they're not realizing all the work that goes behind the scenes to keep that state flowing and everything okay. So what we were trying to do was elevate that importance of the work that is done within the divisions, and that it was important that our legislature commit funds to actually implement changes to make the work more effective. So We take that, we do presentations to the legislature throughout. So let's say the 17-19 session or even this 19 session, we would come to the legislator. We would meet with both the House and the Senate, our Ways and Means Committee, or even the Revenue committees, to make sure they understood the information behind the scenes on the work that we were doing. Okay. So the next slide. This first investment that we received was $5 million. And how we did that is we allocated $3.9 million to our local public health authorities. We do an intergovernmental agreement. That's how we fund them. And what we did is community partnerships. And as it was a small investment and just starting, the focus was to be on communicable disease control. And the communities were to develop their own strategies for limiting eliminating a disease in their area and health disparities. And we left it to them to determine, based on criteria, what they wanted to focus on, because all communities have different issues. So, you have the options, and I'll give you some examples of what work they did in 17-19 to address that. For us, for the state side, we improved our data and collection and reporting. We made improvements to the alert immunization information system, and we improved reporting on public health survey data. As far as the alert system, it's foundational for sharing decisions. So some of the things that we improved is we changed the interoperability to support healthcare providers to know when the immunizations are actually due. We made needed updates to vaccine education modules, which provided families with information about the benefits and the risks of immunizations prior to claiming an exemption. We also convened regional meetings with our local public health authorities for training on the new components of our alert system. And then, next slide. So when we talk about what was done on the local level, again, it was a communicable disease. We were focusing on the disease control. So we would monitor the types of illnesses that are in specific counties, how to respond to them, and how to mitigate that. For types of illnesses that are in the Oregon area are E. coli, Giardia, influenza, hepatitis A, B, and C, Lyme disease, meningococcal disease, pertussis, salmonella, measles, mumps, malaria, dengue fever, and Zika, just to name a few. So we utilized the foundational programs that I showed you on the graphic, and use those foundational programs as the basis to help to inform. So go ahead to the next. With the dollars that were provided, the state approached it a little differently, and we worked with the local authorities and divided the state up into geographic regional areas, and they worked together as a region to address these communicable diseases. Since the money was limited, the 3.9, if you were going to spread that out, we have 33 counties that were participating. If you spread that out over every county, it wouldn't be very much. But by doing regional health equity coalitions, then they were able to have a greater impact. And this slide is just showing you the areas that each of the different counties and sections of the state focused on, based on the type of communicable diseases that they had within their area. We were able to get reach in this manner 33 of our 36 counties We had 2 counties that did not apply. And then we had 1 county, Wallowa County, who has turned over their authority back to Oregon Health Authority. So we take care of their needs, their statutory needs. Next. So this was just some of the findings that we had based on the work. So on the assessment that we did. So for the first 12 months, they saw that they had, in the intergovernmental partnerships, they had an increased ability to respond quickly during an outbreak because they could work together regionally and pull that region together. They were better prepared for public health emergencies because they had that broader team, and they had been working together as a team. They had formal partnerships set for ongoing coordination and resource sharing. So again, you're just really creating more of that partnership and work together. They also worked closely with our tribes and the regional health equity coalitions and other partners to complete the action plans that were implemented. Some of the tribes did not participate. It is up to them, but they were able to actually partner with more than they were planning. They are working with culturally specific organizations to develop some solutions based on the community that they're in. And then the healthcare partnerships, there were improvements. They work with our coordinated care organizations within Oregon, with healthcare providers, hospitals, long-term care facilities to be able to implement the new systems of delivery. And they are implementing strategies to improve the 2-year-old immunization rates and the gonorrhea rates, which we are tracking in accountability metric. And I will talk about that in a little bit more. The next slide. So for public health, we have the metrics, our data, to show how we are doing. And Oregon has a public health advisory board that was implemented. So Oregon Health was implemented in 2016 to oversee this work, and they were responsible for establishing and monitoring whether we were making progress on any of these goals. And so they developed a model for the accountability metrics that both have health outcome measures and then measures that show work that the public health authorities are doing to make improvements. And the metrics report, the top line is a hyperlink to the actual 2019 report for your information. So one of the changes that we saw is that we have seen some modest improvements in the 2-year-old immunization rate. So statewide, between 2016 and 17, the rate increased from 66 to 68%, with similar gains in racial and ethnic groups. We are below where we want to be. We want to be at least at the national benchmark, which is 80%. We've also seen an increase in the percent of vaccines for children clinics and participating in an immunization for quality improvement called AFEX, which is Assessment, Feedback Initiatives, and Exchange. The percent of vaccines for children in clinics participating increased from 14 to 28%. And it's largely a result to the modernization funds in some of our partnerships, and they're engaging in different communities. Another reason, and I think probably one of the for Oregon especially, one of the real reasons that we need to work on our vaccine rates and why it's important is the recent measles outbreak that we've all had experienced. So this next slide is an example of one of our counties and what they did. So in the Central Oregon, they worked with the long-term care facilities in communicable disease prevention. And they implemented a very intense flu vaccination campaign. And then the regional team in Central Oregon moved from county to county to handle the, so they were more nimble in the way that they were set up, that they could go to wherever they were needed. So that they created that partnership. So in the last 5 years, Deschutes and Crooks and Jefferson counties, they had 90% of their outbreaks were in the long-term care facilities. And, flu outbreaks, they result in emergency room visits, hospitalizations, and some deaths. And by partnering with the healthcare facilities, they were able to prevent the spread of the disease among the population. So, that was an exciting modernization and just way to start looking at it. On that next slide, we have a lot of issues in Oregon with, how do we handle these emerging changes? And as climate change is occurring, based on how we handle the outbreaks, thinking of health equity, using our data, how do we help a community to respond more actively and build those partnerships? Those are things that modernizing and being more thoughtful and connected have helped us. So the communities, come together to plan and mitigate these threats, and having a modern public health system that builds that partnership and that resilience, it's very important. In Oregon anymore, we actually had a pretty mild wildfire this season, but it's really more of a whole wildfire season than just one event. We have had so many wildfires. We have a lot of water crisis issues. Salem, Oregon had a huge water issue, and we have environmental issues with different toxins in the air. So having an ability to have a more resilient public health system is what we need to kind of go forward. So next slide. We think about the budget drivers, and maybe it's in some ways it's more of our our risks and our ability to accomplish what we need to based on the funding, the structural funding we have. Is for Oregon, 52% of our budget is categorical federal funding, and they have very specific, it's important work, but it is very specific work and very specific outcomes that must come from that work. So it doesn't really lend itself to the flexibility needed to be able to address the emerging issues of wildfires and climate change and influx of population. Oregon continues to grow, and we also risk the same as other states is the uncertainty of our federal funds. We are going through issues now with our reproductive health, and due to changes in federal regulations, have had to make some pretty major changes within Oregon as far as accepting federal funds. So you have to figure out, how do you continue to go forward with the important work of modernizing when you may have limited resources. And then we also have issues of the local participation. So we have some counties that are unable to continue to afford to do the work, the important work in the county, and they're turning over, or they've looked to turning over their authority back to us as the state. And currently we have one county that has done that, which is Wallowa County, but with the ongoing issues that they're having, that may come up more often. And an unusual bullet there with the declining medical marijuana revenue. Oregon had a very unique system of utilizing revenue from the medical program, and the legislature allocated that to support core public health, and that is no longer an ability for us to have those types of funding, so that reduced our funding level as well. Next slide. So where are we going? We are just continuing to build on the system that we've started with the state, the local, and now our tribal authorities. We want to be ready to respond to emerging issues, and we, public health is data driven, and we want to make those decisions that are, based on science, based on good data, and we want to have resilient communities that are ready to address the health threats that Oregon has, and focus on the goals and expand those opportunities. So next slide. We are taking, and this is our Public Health Advisory Board. When we began this journey, it was determined that we would do a phased approach, realizing that, it's going to take some, probably a few biennia before the legislature will be able to completely fund us at the level that we need to be at. And so we took, looking at 4 phases, and we took the first phase of addressing the communicable disease, and now in the 1921, we're continuing with the communicable disease, and we're adding environmental health as a focus to begin increasing the money that is actually allocated to the locals and within public health for that. We're excited for that. Next slide. This shows our with the money we received. So now, we have 15.5 million, but we received the additional $10 million this biennium, and we're continuing to build upon what we were doing, adding the lens more so with the health equity. And this biennium, we were able to add the tribes into this. They will begin doing the assessments that we did in that gap assessment. So on our tribes, as they are sovereign nations, if they choose to take part in the assessment, they can. They do not have to do that, but if they would like to, they can. And we are continuing. So a lot of the function that we have for this biennium is to continue not just modernizing the data, but our actual systems, and update our data systems so that we're able to capture it in a more meaningful way. At the state, we're working on data visualization so that the information that we're putting out for Oregonians can be utilized in a much more interactive way. We are also working towards the communicable disease investigation, continuing to decrease that gap, continuing the work on the immunization and reducing the STIs, and then, as I said, begin addressing the environmental aspects of it. On the OHA side, we were able to get some new positions in this session. So we have hired a health equity coordinator who will be working across our agency as a whole and with our partners to make sure the work that we're doing is that we are taking that health equity lens in all that we are doing. We also were able to add staff members in our acute and communicable disease, so looking at the disease prevention, and we were able to add staff to work on the environmental side. On the public health side, they are going to basically continue to do the same. They will continue working in the regional partnerships and just investing more in the disease, decreasing the diseases and trying to eliminate some of the gap. And then for the tribes, they will be, some of them, actually we had 3 tribes that had already completed the modernization assessment, so they'll go into the more implementation, and then the rest of the tribes can do the assessment and then move into modernization. So, so next slide. Now we really, and I said at the beginning, I feel like we're really just beginning our journey, and it is, because now it's like we have an investment from the legislature, and we have 2 years to really show them changes. And it's not just giving the money out to the states, it's also changing the way we do work within the division. And so we contracted with a change management group, and we did an internal roadmap. And so that included the executive management team. So we had 2 teams, the executive management team, which again includes our public health director, my role, our policy, and our center administrators. And we created our vision, and then we had we call it the change team, but it's staff within public health that some were managers, some were staff in all of the foundational programs to get their input into, what does this mean? And then we're working, and we are continuing to work on developing that shared language and understanding of what it means. And so one of the interesting things that came out is they did an assessment within this group, the change management facilitator assessed the readiness of leadership, and we assessed the readiness of the change team, and we weren't on the same page. And that was very important. And so what we did as the management team is we then took a step back and worked with another consultant to develop a visual representation of what do we mean for change. And I can't share that yet. It hasn't quite gone out, and it has to be within public health. But we wanted a piece of paper that would help us talk about what modernizing public health means, and make it so that everyone in the public health division can find themselves in that plan. Since you're talking about, you have foundational programs, and others within public health could say, well, wait, do I really fit? Yes, you do, and the work you do is important, and this is why, and we can show you that. So we are in the process of holding staff, we call it our fall forum, and the focus of our fall forum is for all staff within public health. We have about 600 staff members here that will be going to numerous sessions that where we will introduce the visual. And each of us on the leadership team, we have probably 8 or 10 meetings and so we've all split that up, and then we're all, I have one this afternoon that I'll be introducing that visual, and then leading small groups to kind of talk about it. Not it's like, what's your reaction? How do you feel about that? Do you fit? So that people begin to understand where we are going and how they all fit in and what will be changing, because nobody likes change. So we're trying to make sure we're involving our staff as we go forward. And then in January, we have 2 all-staff meetings, and again, our focus will be on the modernizing of public health, and we'll be bringing speakers in, and then again, as the leadership team, we will be taking an active role to continue that discussion and just continue explaining and working towards modernization. So, when we think about our current status and how we work and the changes that we're trying to get our staff to understand is we have a tendency, and a lot of that has to do with the way we're funded, because we have sections, and in a section you could have numerous staff members and focusing on different programs, and so they're still siloed within themselves. And we want to break those silos down, so we are working on creating the cross-sectional collaboration. We are working on, getting staff that are more nimble. Just as the counties had staff that were regionalized, that's what we're trying to get to for our staff, that you could have you have an outbreak, you have something, you could take staff from other areas and bring them together. And then we are talking about our funding, and this will take time. We have to figure out ways that we can work together as programs that still meet the requirements of the CDC grants, but that they can apply for, differently. We have some programs that are now applying for grants that are cross-program, and that again is beginning those types of discussions. Quickly go through the next is our this is kind of the plan that was outlined by the change management group. And so for public health right now, we're concentrating on the first 3 priorities, really making sure leadership is engaged, that you have the sponsorship, and that we are implementing that and making sure we have the language that we need and kind of put the systems in place so that we can begin implementing that into all the sections in the work we do. That's our first priority. The next slide. We will continue providing updates to our legislators. We will be developing our next policy option package for the legislative session that will happen in the 2021 for the next increment for modernization funding, and we will continue to work on implementing our practices with the divisions and working with our partners. Our goal is to have a fully modernized system, and we have accomplished the hardest part of that, is that we do have a good understanding and support from our legislators for the work, which is exciting. So any questions?
Thank you, Carole, for that very wonderful presentation. And I really appreciated when you talked about your role in change management and the quality improvement pieces. I thought that was really interesting. But at this time, we will open it up to any questions. And I believe you can either speak directly by muting your line, or you could type your question into the chat feature. Perhaps while we're waiting for people to type in their questions or think of their questions, Carole, if you could talk a little bit about how your team and sort of just going through this journey has really your partners' perception of the value of prevention. So some of those external partners you talked about, working with the legislature and other partners.
About the value of how we talked about the value of prevention?
Yeah, I guess my question was, how has sort of going through this journey, how has that enhanced your partner's perception of the value of prevention? Have you made headway that way? Do your external partners, are they able to sort of articulate better the value of prevention?
Yes. Yeah, so a lot of the external partners are the local public health authorities. So they're kind of with us as we're trying to work on informing the legislature. I think the biggest education was to our legislators, and really giving them very practical experiences of what does public health mean? What is this broad category of our work? And we had one of our physicians that talked about the hepatitis C, and that it's an very viable issue in Oregon, but we're not funded for it. And how he just went through all the different steps, and how preventive you can be if you actually have the funding to address it, and put it in a language that helped them understand just a very practical change of, this is something we do, and yet you don't fund this. With the measles outbreak, that was an example that we could give to say, this is very important work, and you need to be funding us to be able to have the necessary funds to be able to address these things. Salem, for Oregon, we had, and of course that really hit home quite well for them, because it was down at the Capitol, where we had a cytotoxin outbreak in the water system, and so they were having to have bottled water for quite a while. And public health does that, and we're saying that's emergency preparedness is there. We activate our incident management team. We have our investigators that are figuring out what these, what's the source of this outbreak. So we did a lot of educating and providing examples to items that were pertinent to Oregon, that helped the legislators to really get a better and a broader view of what public health was. So I think that is probably one of the biggest barriers, is that I don't, in many states, I'll speak for Oregon, but they just didn't understand the depth and the breadth of the work that was done. And when that was all outlined, it was like, oh my goodness, yeah, this is very important. Does that answer your question?
Yes, thank you. Thanks for sharing. And we are coming up on the top of the hour. I just want to make sure no one else had a question. We do have a few updates to provide before we close out the session. But if anyone has any question, now's the time to ask. So hearing none, I just want to take a couple of seconds to provide you with a couple of updates that we have. And I want to thank Carole again for that presentation and the discussion afterwards. So our first announcements is that over the next couple of weeks, we'll be publishing a wonderful video interview featuring your peers and senior deputy respectively from South Carolina. And I think Darby is on this call. So I just want to thank her for that terrific video. The interview emphasizes the importance of the CFO senior deputy working relationship in making an impact at your agency. And so we'll be sharing this video through ASTHO's social media channels and on the CFO peer network, my ASTHO community, among other venues. We do ask that you please share this with your executive management team, and specifically your agency's health official and senior deputies and CFOs. So stay tuned for that. I think you'll really like it. The second announcement is to save the date and stay tuned for more information on our first executive leadership peer network call, scheduled for Friday, October 25th from 2 to 3 p.m. The Executive Leadership Peer Network, in case you're not familiar yet, is a new format combining all peer networks, including CFOs, senior deputies, workforce directors, legislative liaisons, public health lawyers, and chief medical officers. These calls will include a general session on topics like federal and state legislative updates, a public health issue or topic, and its implications across each of the executive leadership group. And then they'll close out with a peer network breakout. So we look forward to your participation in these and also your feedback on this new format.